The etiology, the common one are the tumors, and these tumors can be benign or malignant. That's what the general classification we come across in rest of the medicine. But here in endocrine, the difference is either functional or non-functional, because the tumors of the endocrine generally are benign, but they have got tendency to secrete hormones, and these hormones are effective at a distance place. So these functional tumors and non-functional tumors are important, because it may be benign, but if it is functional, it will be causing some disease presentation. It may be causing problem to the patient, a small benign tumor. Or it may be a non-functional tumor presenting as either functional loss of that particular gland because of a space of convolution, or it may be compressing the surrounding structures, presenting as a mass effect of that particular tumor. The diseases may be autoimmune, they may be organ specific, they may be generalized to involving multiple organs, endocrine organs, and they can involve a specific organ as thyroid gland only, or it may involve polyglandular presentation. Autoimmune diseases are again one of the common presentation. Different enzyme defect can present with either hormone excess or hormone deficiency syndromes of these patients. Or receptor defects again can be hyperstimulation or understimulation of the receptor. So the basic difference of the endocrine is it's not the disease itself which is physically affecting a organ of the body, but it is the secretions of that particular organ which are important for the body, and hypersecretion and hyposecretion, which may result from any disease involving the endocrine gland, can present by its own symptoms as well. Again, remembering this disease is not limited to the etiologies which we have talked about. It is the drugs, and there is a list of drugs which can affect the endocrine glands and their secretions and their actions on the peripheral target tissues. They can all be, and the drugs may be affecting more than one gland as well, more than one system as well. And there is a list of medications which can, and many of them are very commonly prescribed, and this is there in your book for your reference. I have kept it here, so you should remember whenever taking history for potential endocrine disease patients what medications they are on and what are the effect of these medication on different endocrine gland secretions and action of different hormones on the peripheral tissues. Functional classification, as I've talked about, these are the secretions which are taking place on different organs, once at times, many a times more than one organ of the body, one side of the body. So functionally they have to be classified, and they may be hormone excess, simple, in which the more hormone is being secreted, or it may be hormone deficiency, in which you find less hormone present in the body, or it may be a hormone insensitive hypersensitivity, that's a receptor defect, in which the amount of the actual amount quantitatively the hormone remains the same, but its effect is accentuated at the peripheral target tissue level because of the defect in the post receptor signaling or the receptor affinity to the hormone. Or it may be the receptor resistance to the action, that either the receptors are not present or not affinitive, not binding to the ligand, or the post receptor signaling is affected, resulting in resistance at peripheral target tissue level. Though the hormone may be more abundant in the blood level, blood levels may be higher in these cases, but the action is absent, as in case of testicular feminization syndrome. Or as I've talked about, the very tumors, they can present as a mass effect. They may or may not present with hormone excess or hormone deficiency, but they may present as a mass effect, as in case of pituitary adenoma, where it can present as uh, bilateral bitemporal hemianopia or anosmia or something like that, in which it is not endocrine presentation, the endocrine secretions are fine, but because of the mass effect of that tumor, peripheral tissues are affected and they present. When it comes to the hormone excess or hormone deficiency, it may be primary, it may be secondary. When we label someone a primary, it is when we talked about a particular hormone secretion which is being secreted by an organ. For example, we are talking about, if we are talking about thyroid, so thyroid is being secreted by thyroid hormone, thyroid gland. So if the disease is involving thyroid gland and it is related to the thyroid hormone secretion, it is a primary thyroid disease. But if it is the trophic hormone which is actually controlling the thyroid and disease is placed there, and thyroid itself is normal, but it's hyper responding because the trophic hormone is, for that matter, TSH is secreted very high number. That's how that T3, T4 is secreted more from the thyroid gland. So this actually thyroid gland is normal, but thyrotoxicosis is secondary to the some other organ dysfunction. So if the disease is placed in the same organ, same endocrine gland for which the secretion is manifested, thyrotoxicosis, for to say that the thyroid gland is abnormal, then it is primary. If the thyroid gland is normal, it is the pituitary or the hypothalamus, which is causing more secretion from the thyroid gland. It is secondary. So it may be primary or it can be secondary. Similarly, deficiency may be primary or secondary. If the thyroid hormone deficiency is because of the thyroid disease itself, it is primary. But if it is because of the pituitary disease, it is secondary. So this is how it works in the nomenclature of endocrine, the primary and the secondary. And then the failure again, failure of inactivation of the hormone in hypersensitivity, in which the metabolism of the hormone is defected, so that active compound of the hormone is not being removed from the circulation and stays more in the blood. For example, if some hormone was supposed to stay for few minutes, and if it stays for a few hours, more action of that hormone would be seen, and then hyper action, hyper functioning state would take place. This kind of inactivity, this is maybe the mechanism behind the failure of inactivation of the primary hormone, or it may be the receptor or post receptor signaling defect of that particular target organ that may be responding to exaggeratedly to the similar amount of the stimulus by the hormone. And the hormone resistance, again, it may be because of the inactivation of the hormone early, or it may be because of the target organ's resistance to the receptor or post receptor signaling similarly. So the tumors may be benign and malignant. We have already discussed about it. When it comes to physiology, these are endocrine secretions. They may be amine, they may be peptide, they may be glycopeptide, they may be steroids. The secretions may be endocrine, paracrine, or autocrine. When the secretion takes place from the cell and affects its own function, it is called autocrine. When it affects neighboring cells' function, it is called paracrine function. And when it is secreted into the blood and affects the distant target organ, that may be more than one or limited to one, as whatever the case may be. In that case, it is endocrine. So we are dealing here with the endocrine secretion, and they may be amine, peptide, glycoproteins, and the steroids. So the hormone is secreted from endocrine gland, and it is under the influence of a trophic hormone. There is some feedback mechanisms. There is always a dynamic control between how much has to be released and how long it is to be released, and when it's going to stop and when it's restart. That all is a trophism, and that trophism is again under the influence of some other gland, master gland. Or it may be metabolic stimulus, as in case of glucagon, it is because of the hypoglycemia, it starts to release. Or it may be glucose again for the insulin release, or the parathyroid hormone, which is a calcium state, manages calcium state. So it may be the metabolic stimuli, or it may be the trophic hormone stimuli, which is causing the this sorry, this hormone to be released. This hormone, once released in the bloodstream, as we've talked about, we are dealing with the endocrine, and it has to be released in the blood. And when it is released in the blood, it is carried out in the circulation by a certain transport protein. These transport proteins may be specific to this particular hormone, or they may be generic, such as albumin and prealbumin, which are present in the body. They carry these hormone, and that affects the total amount of the hormone present in the blood. The hormone itself may be very high, but active hormone is usually the unbound hormone, which is biologically active. So it can again affect the regulation of the CD state of that particular hormone, how much the binding globulins are there, how much other binding proteins are there. If the protein are less, more action could be taken place, because more biologically active hormone, even with the normal secretion amount of the secretion of the hormone, total hormone secretion, the action, peripheral action would have been enhanced. So that is one of the way. Then the target organ receptors. These receptors may be at the membrane, and most of the amine, peptide, and the glycopeptide, they have got membrane receptors, because these are hydrophobic, hydrophilic molecules, and they do not cross the lipid layer. But it may be in the nucleus, for particularly for the steroid hormones. Intracellular signaling, different pathways of the signaling are there. It's beyond the scope of this particular lecture, but you have to revise from your biochemistry and the physiology the different signaling pathways of different hormones, and we'll usually deal when it comes important in the disease manifestation. And these hormones, they can affect locally in the cell by affecting the membrane transport proteins, such as the case the insulin, in which it increases the glucose uptake, or it may affect the certain proteins and enzyme effects, as in cases of lipolysis. Insulin again in the lipid tissue, it affects enzyme activities and causes lipid deposition, or it may be gene expression and changes. So the actions on the membrane, which may be start within few minutes and last for few minutes also. Those for the enzymatic activity may be minutes and hours, and those with the gene expression may be days in the weeks to take place, and the same time it would be revert slowly as well. All these mechanisms where actions have got a negative or a positive feedback over the secretion through a master gland again that affects the secretion. Though that is a cartoonic presentation, we will be discussing in individual diseases what is this axis. This is called the axis of control of this, and most of the hormones are actually under control of pituitary and the hypothalamus and pituitary axes of that particular gland. We are going to discuss today for the hypothalamic pituitary axis of adrenal gland, HPA axis, and we will be shortly coming in the next lecture. These are the axes for this is for the gonadal hormones, these for the thyroid, there is again for estrogen, and for lactation, and this again you can see for the growth factor in the growth hormone axis. Here this is what we are going to discuss today, the circadian rhythms of the cortisol secretion, CRH, cortical releasing hormone from the hypothalamus, which affects the release of the ACTH, and that ACTH affects the target organ, that is the adrenal cortex in this particular case, and releases the cortisol and androgens from the target organ and the adrenal cortex, and that affects the stress and the metabolism of the body. So these are excesses of different hormones, and they will come repeatedly discussed in individual hormone disease syndromes when we are going to discuss those. Again, some of the endocrine glands which are present in the body: thyroid, pancreas, kidney, testes, bone, pituitary and hypothyroid, hypothalamus, and the parathyroid glands, breast, adrenals, and the ovaries. And then there are the diseases which they cause, Addison's, Cushing, Cohn's, and the pheochromocytoma. These are the adrenal diseases. You already have the lecture on pheochromocytoma. Today I'm going to talk about the Cushing as well. My next lecture would be on Addison's. Probably you would have some idea, lecture on the Cohn's as well, if I remember. So there are all these glands are associated with some of the diseases. Broadly speaking, these diseases either would be a hyper functioning hormone disease or a hypo functioning hormone disease. These are the broad categories, and that may be because of absolute increase of the hormone or decrease of the hormone, that is primary or secondary hypersecretion or hyposecretion, or it may be a receptor defect or a sensitivity defect at the target organ level, and that can when the primary organ itself is okay, the secretions is okay, feedback system is okay, but the target organ actually is insensitive or hypersensitive to the response to the particular hormone. Presentation, when we talk about the presentation of endocrine, these are very non-specific. Few of them are organ specific, but most of them are non-specific. They may present with lethargy and depression, weight gain or weight loss, or they may present with polyuria, polydipsia, heat intolerance, palpitation, headache, muscle weakness, causing of a fissure. No, none of these symptoms actually are looking into a specific system of the body. That again is one of the feature of endocrine disease. It is not a organ specific disease. Most of the time, most of the endocrine gland secretions are affecting the many organs of the body at the same time. So their symptoms are not localized in cardiovascular or respiratory or abdominal or the CNS symptoms as many of the diseases manifest themselves like. they present as a multi-system disease, and they have got diverse action. These hormones have got very diverse action on the body, and same hormone can have a different action on different tissues. As I gave initially the example of insulin, in which it may affect, it have got a different effect on the liver, and completely altogether different effect on the muscles and the brain, and again other way around effect on the lipids and the adipose tissue. So the same insulin have got different receptors in different tissues, and they manifest different, they take over different actions in different tissues. So the hormone remains the same, regulation remains the same, the action remains different at different organs. So that's how it presents with the multi-system disease. When any endocrine gland is involved, it affects different and manifestation. This lethargy and depression may be manifestation of the thyroid, hypothyroid, diabetes, hyperparathyroid, or it may be because of the hypogonadism. It may be because of the adrenal insufficiency, Cushing syndrome. So many on a single symptom, you can never say that this organ is involved or this gland may be involved. It is the constellation of the symptoms which make a case of this may be the cause, and we have to learn that art, how to constellate the symptom of the patient and look into the potential cause of the disease involved. Weight gain again is a hypothyroidism and Cushing. For weight loss, cytotoxicosis, adrenal insufficiency, diabetes mellitus. Polyuria, polydipsia may be diabetes mellitus, diabetes insipidus, hyperparathyroidism, hypokalemia in Crohn's, heat intolerance and thyrotoxicosis, and menopause, cold intolerance for hypothyroidism, palpitation or thyrotoxicosis, and pheochromocytoma, headache for acromegaly, pituitary tumors, and pheochromocytomas, and muscle weakness, thyrotoxicosis, Cushing, hypokalemia, hyperparathyroidism, hypogonadism, they can all see. And then causing is acromegaly and hypothyroidism. So when one patient present with different symptoms, we constellate the symptom and look into the potential secretion or the gland which may be involved when we are suspecting an endocrine disease. Coming to investigation again, this is the most of the hormone levels we have got assays available, but a raised assay or low assay may not actually translate the disease itself. We may need a dynamic testing in which we see the trophic hormone and the target hormone, and then again this levels can vary with the binding protein concentrations as well. If somebody have got some problem with the protein metabolism, they may have effect on the endocrine presentations of the hormones which these protein carry. Then comes the imaging, and again imaging could be functional and it could be static. MRI brain would be a static image, but a octeroid stain or a thyroid stain is a functional imaging in which the active tumors can take up and inactive tumors can show as a cold nodules, and this again is a dynamic imaging. Very few cases we would require histological diagnosis, particularly in case suspecting of the malignant tumors, but most of